Bismillahirrahmanirrahim. I start the CME with the name of Allah, who is very, very kind, helpful, and merciful. CME updated by Mother and Child Survival Group of Pakistan. And me, Dr. Tariq, Gynae Family Emergency Specialist, Internist, Gulf KSC, presently a district gynecologist. Let's talk about a brief review on the stroke. Investigation and brief management. Stroke, it can be due to a cerebral hemorrhage, or it can be due to ischemic stroke, which can be due to thrombotic and embolic phenomena. The hemorrhagic strokes are sudden rupture of a vessel in the brain. And actually, what is stroke? Stroke is basically an area of the brain which is supplied by the circle of Willis. Includes anterior cerebral artery, middle cerebral artery, posterior cerebral artery, and basilar vertebral arteries, and the basilar arteries. So they all supply. And if there is any rupture or there is any blockage of this, these cerebral arteries, cerebral or vertebral arteries, then there is decrease in the supply of blood to the vital organs of the brain. Hence, there comes the severe headache, unconsciousness, and focal deficits. Depending upon the type and severity of the hemorrhage and thrombotic or ischemic strokes. So this is you have to have a very you have to see this applies here the same risk factors as in diabetes, hypertensive, ischemic heart, and others, because basically these thrombotic strokes are basically due to the deposition of the cholesterol into these vessels, like that is of coronary arteries, and that now in the cerebral arteries. An embolic phenomena also occurs because of atrial fibrillation, long-standing chronic atrial fibrillation throws an embolus or deep venous thrombosis. This thrombus, they get dislodged and they lodge into one of the cerebral arteries. So patient present with acute severe headache, hypertension, uncontrolled hypertension, and unconsciousness, seizures, uncontrolled hypertension, raised intracranial pressure, and unconsciousness and coma, depending upon the severity of the etiological factors. As compared to, and the most important thing is that you have to do the you have to maintain the airway, breathing, and circulation. For example, if the patient is having Glasgow Coma scale less than 8, then you have to ventilate the patient. And then you have to do certain neuroprotective measures, like to maintain normoglycemia and do not allow hyperglycemia if the patient is diabetic, and normocapnia and hypocapnia. These are the ones which are important neuroprotective measures, and to see the first thing in the emergency is to put the patient for the non-contrast CT scan. This will detect you differentiate between an hemorrhagic stroke and the thrombotic or embolic stroke or ischemic stroke, hemorrhagic stroke or ischemic stroke. Because in the CT scan, hemorrhage comes as a black shadow, white shadow. The black shadow comes, ischemic area, blackish comes in the ischemic stroke, whether due to thrombosis or whether due to embolic phenomena. But white shadow comes as of hemorrhage due to rupture of a vessel, cerebral vessel, or the most important are the basically the lenticulostriate vessel leading to basal ganglia, and then to the putamen and amygdalite and thalamic vessels. So then the focal neurological deficit depends upon to the areas. The hemorrhagic stroke leads to the uh, hemorrhagic leads to the area paralysis of the body, focal signs on to the opposite side of the body, and eye signs also depends upon uh, the hemorrhagic and the ischemic stroke. And so the acute management is to do the CT scan, the airway, breathing and circulation, and then the uh, uh, neuroprotective measures, which I already mentioned. And then comes we'll talk about briefly about the ischemic stroke. For the ischemic stroke, the most important thing is it has to confirm that whether it is due to uh, mm, the CT scan has shown the infarcted area and the blackish part. And it does not appear, but it shows that this area is ischemic, and has a blackish type of shadow on the CT scan. So if the patient comes between 3 hours or less than 3 hours, then it is important to give the TPA, plasminogen activators, to lyse the clots and thrombosis. And the important thing is that blood pressure is not to be lowered as compared to that in the hemorrhagic stroke, where the blood pressure is lowered early. But here is a permissive hypertension is allowed, so that it should not have a more complications, especially, and that can lead to, for example, hemorrhagic stroke into ischemic stroke, and ischemic stroke into hemorrhagic stroke. So in ischemic stroke, the blood pressure is not lowered very rapidly, rather a upside high blood pressure is allowed, so to avoid the complications. And then naturally, if the patient is diabetic, it has to be hyperglycemia should not be allowed, and patient should be kept normal glycemic, and the other measures, and the patient posterior airway and nutritional, and all these things, they have to be sorted out. Blood pressure has to be controlled, but in ischemic one, it, as I have mentioned, that it is not uh, uh, rapidly lowered as compared in the hemorrhagic stroke. And also then you have to consult the neurosurgeons or neurologist for the important for the stunting, or for the primary uh, PCI of stunting and carotid and arterectomy, or all these procedures, which depends upon the neurosurgeon and neurologist to be. While for the and you have to do then HbA1c to triglyceride levels and all these things, and then for you see later on you have to have antihypertensives and to be given, and can give aspirin also, clopidogrel also, and then statins in high doses, they are needed for chronic and then the physiotherapy and the dysphagia, and for the dysphagia, and for the other paralysis physiotherapy for the, and all these, this is important. And then for the hemorrhagic stroke, it is very important to first see the CT scan, And when there is whitish area, it is confirmed that it is hemorrhage. The management of ischemic stroke and the hemorrhagic stroke is totally different. So then we have to see the raised intracranial pressure, see the level of deficit, and see you have to consult also the neurosurgeon for the rescue of the hematoma, and sometimes the craniotomy is also needed to have the pressure effects on the brain that the neurosurgeon has to tell you. Of course, the conservative measures and all these, and normoglycemia and the hypoxia, all these have to be treated simultaneously. And the important thing in the hemorrhagic stroke, as I've told you, that the blood pressure has to be kept low, and it has to be below 180/80. Like in the ischemic one, it could be 220/105. It should not be lowered rapidly, as a permissive hypertension is allowed there. So it all depends in hemorrhagic stroke. If the hematoma is pressing too much, or if there is then neurosurgical is needed, opinion is needed, or for the sometime they develop obstructed hydrocephalus also. So that has to be sorted out with the help of the neurosurgical colleagues for the evacuation of the hematoma or for the craniotomy. And for the obstructed hydrocephalus, if they want to put some drainage procedure. And then blood pressure I have already told you, and then his hyperglycemia should not be allowed, that it will increase the mortality more. And then it's a multi-specialty and multidisciplinary approach with neurologist, neurosurgeon, and the physiotherapist, and all these. And in also you see the causes of hemorrhagic stroke are the rupture of the cerebral vessels, vertebral vessels, and all these. And also there is in the elderly, amyloid angiopathy, and anticoagulants, patient on the anticoagulants. So reversal of anticoagulants are also very important. And then in these patients, we reversal of anticoagulants like patient on heparin must be with protamine sulfate and with the warfarin. Oral anticoagulants, then FFP and vitamin K. And then of course, as I've told you, blood pressure could have been controlled. In the later on, this nimodopine is also given to prevent the vasoconstriction, which can lead to complications in the hemorrhagic stroke. So this can happen also in these strokes, hemorrhagic strokes, or ischemic stroke, then can happen also in the pregnancy. So basically the management is the same, but there are other things as well, as in pregnancy induced hypertension, and then preeclampsia and eclampsia, which also presents with the high blood pressure and controlled hypertension, and hypovolemia, albuminuria, and unconsciousness, and the seizures. And the seizures in the hemorrhagic strokes are, if they are there, then it can be controlled with the diazepam, but in magnesium sulfate is given in the patients of eclampsia. But if the seizures for prophylactics, no, they are given. And steroids are also not given unless if it is, but you can give this diuretics, like if the osmotic diuretics like mannitol and others, hypertonic saline. So this is a brief review of the stroke, hemorrhagic stroke, embolic and thrombotic, or with the hemorrhagic stroke. So of course the chronic management will all depends upon the role of these statins, but in that the aspirin and clopidogrel in hemorrhagic, they are not given. and reversal of anticoagulants are done. Control of the diabetes and hypertension and the diabetes is all that mandatory. And then the physiotherapist and the other exercises and all those necessary for that. Thank you very much for your attention. We must have follow our great God Almighty, and we must recite La ilaha illallah Muhammad Rasulullah, Allahumma ajarna minan nar, and Allahumma ajarna minan nar, save us from the fire of Jahannam, La ilaha illa subhanaka inni kuntu minaz zalimin. And we'll be discussing with another, this is a brief review of hemorrhagic and hemorrhagic and ischemic stroke. And the most important thing is to anticipate it, and in the emergency you have to do airway breathing and circulation, and then neuroprotective measures, and then you have to send it for CT scan to see sure that it is hemorrhagic or thrombotic, and then accordingly to deal with it. As in thrombotic, you have to, if 3 hours before it has reached, then TPA, and then others like aspirin and clopidogrel and statins, and control of blood pressure. But permissive hypertension is allowed in thrombotic one. While in hemorrhagic, it is different management, and if it is leading to brain edema and all that, so that needs to be controlled, and raised intracranial pressure also. And then if the evacuation of hematoma and your craniotomy and your surgical colleagues intervention is needed. Also in hemorrhagic stroke, this stunting is done in carotid endarterectomy to remove that clots. Thank you very much for your patience. We'll come with another review.